Right, on to our amazing guest speaker tonight. I'm going to do a proper introduction tonight, Gina. So you might. Gina Brown, Professor Gina Brown, and yeah, Professor Gina Brown is chair of the Gastrointestinal Imaging and Radiology in the Department of Surgery and Cancer, Faculty of Medicine at Imperial College London, and also an honorary consultant radiologist at Imperial College Healthcare NHS Trust. Her research focuses on improving the accuracy of pre-operative assessment of colon and rectal cancers using imaging, enabling more tailored treatments based on accurate prognosis. For those of you like me who struggle with the terminology, this is about your chance of survival in treatment runs. Prof. Brown's research in colorectal cancer staging has set the national and global benchmarks for imaging assessment of bowel cancer patients before and during treatment. These improved methods reduce failure in high-risk patients whilst avoiding over-treatment of low-risk patients, and resulted in MRA-based strategies being incorporated into several guidelines such as peer review measures, UK, NICE and global guidelines. Gina has contributed to the NHS workforce development through teaching on large-scale national training initiatives. An amazing woman. So if you need an MRI image assessed, Gina is your expert, without a doubt. Not only is Gina a top clinician, she's a wonderful person trying very hard to improve the lives of patients. Please welcome Gina.
That's a really lovely introduction. Thank you, Paul. And really congratulations on all that you've achieved with the charity. It's amazing. And I think from somebody who's applied to so many different funders over the years and with varying success, the thing that's impressed me about Red Trousers, the Red Trouser Day charity, I should say, is the way in which you really engage with the patients to figure out what is a priority and transmit that information back to you. And then events like this are so important. But the other thing, which I think is even more amazing, is one that there's no overhead. You've limited your overheads, which is unique. Basically because you're giving up so much, everyone is giving up so much of their time for nothing. And that's so hard you don't see that in other charities. And what that means is, firstly, you're nimble with your award sort of giving, as it were, which means that people who get a research idea can run with it. And that's what you've enabled us to do. And we wouldn't have been able to do that without all of your support. So this is really, it's such a pleasure to share with you what we're going to be doing and how it will hopefully improve the lives of patients diagnosed with bowel cancer. So Mercury 3, that's the title, which is to improve the diagnosis and treatment for patients with rectal cancer. Now, why is it called Mercury? We started in, I think, 2001 with the first Mercury trial. And that did change things because it allowed MRI to be adopted where previously it hadn't. But what we face currently, not just in the UK, but around the world, is a staging system that hasn't moved with the times. It's not accurate for prognosis, which means that when you have your scan and it's reported using this old system, which is the national and global standard, you end up not having a full picture of what the disease is going to do. And that means you can't make an informed choice about the treatments you might have. And it also means that we're not, collectively, not documenting the staging information as well as we could, which then means we can't look into how to improve the outcomes because we don't know what we started with. And that's so fundamental, and how much does it cost to do that? It shouldn't cost anything to document things well. And, the old adage of that which is not measured cannot be improved upon. And it's so fundamental. And yet there is so much resistance to it because we're in this vicious cycle of, well, you haven't got the evidence to change things, therefore we're not going to change things. And so this is why Mercury 3 is so important, because we are going to create and generate the evidence to change things. And we're going to do it fast. You're not going to wait 10 years for this. We're going to start changing things within the next 12 months, which is why your funding stream has been so important. If I contrast this with something like CRUK or NHS funding streams, you have to put an application in, it takes a year, and then there's another 6 months, and then eventually you'll get the funding, and then you try to open it. And by the time you have got through it, 10 years has passed. And we can't do that. We can't do that. This is why it's so urgent. This bar chart, it's a strange looking bar chart, but essentially in blue are the patients who go to surgery without any preoperative treatment up and down the country. And these multicolored bars are the various preoperative treatments that patients receive. And this is hospital by hospital. So what you're seeing here is the graphic display of the postcode lottery. And then it gets worse, because the next chart shows the impact of postcode lottery, which is there's no relationship between the treatment the patients are getting and their outcomes. It's shocking, because what you're getting is a range in survival that's down there to up here. And nobody knows why, because nothing's been documented. The staging system isn't fit for purpose, so we can't understand why this variation has happened. So we're using a staging system that was invented in 1932. And it's 2026, almost 100 years later, we're still using that staging system. It was based on this lovely pathologist called Cuthbert Jukes, who was based in Harrow, not in Harrow at the time, it was in East London, the St. Mark's Hospital for bowel cancer. And he studied the specimens of the surgeons at the time at St. Mark's in the 1920s and 30s, and showed that if the specimens had lymph nodes in them that were malignant, the survival for those patients was very poor. 7% survival. Can you imagine that kind of survival? But that's what was par for the course in sort of memorable lifetime. The thing is, he based his staging on the kind of surgery that was standard in the 1930s, which was this kind of surgery. It was done very quickly. The surgeon would go in and literally pull the rectum out. There was no dissection. There was no art form here. It was very rough and ready. And it is no wonder that if the patient actually survived their operation, they then wouldn't survive much longer, because half the disease was left behind. And in fact, the lymph nodes relationship between recurrence was more a marker of poor surgery, not necessarily that the lymph nodes themselves were responsible for patients not surviving. What happened as I was starting my research in bowel cancer was the development of better surgery. This is now the standard, thank God. So surgeons will operate on the bowel in the rectum following a very defined plane and deliver the tumor and all the disease around it in a sausage, literally like a sausage. Everything's enclosed. It then has resulted in the fact that the lymph nodes are no longer responsible for patients dying from their disease from recurrence in the pelvis. And so we have to think about why it is a patient doesn't survive their disease and what we can do to mitigate that. What can we do to improve the outcomes for these patients? Now, when I was starting out, and what the current NICE guidelines are based on, sadly, is the digital rectal examination. And for those of you who've had a prostate exam, you'll know what that means. And for those of you who've had a rectal cancer, you also know what that means. But essentially, the surgeon inserts the finger, and this is why this isn't so good at Christmas dinner or a golf club dinner, but at least you've, you're not eating right now. So the finger is placed in the rectum to see if the tumor will move. And if it's fixed, i.e. they can't move the tumour, they'll say it's advanced. And if they can get it to wiggle a bit, they'll say it's an early stage. And so back in the 1990s and early 2000s, upon which all these randomized trials data is now being used to as our evidence base, because there hasn't been any repeat of those trials since then, they said, well, okay, you know, if you've got an advanced tumour felt to be fixed or tethered, they should all get radiotherapy. And actually the mobile tumours, the results of the trial suggested that maybe you should give radiotherapy as well. So those patients are randomized between radiotherapy and surgery, primary surgery. And so these guidelines that we're now running on are from historic badly staged tumours where things were not documented well. So we're really in a stuck position. So despite the advances, we haven't fully utilised their potential in current clinical practice. So we've had improvements in surgery and improvements in staging, and yet our guidelines haven't kept up. So something urgent is needed to generate the evidence base to turn this thing around. And what we did initially in the late 90s and straight into the sort of early 2000s was establish that MRI could at least demonstrate to the surgeon if operating on a patient will result in a cure locally in terms of not cutting through tumour, not leaving tumour behind. This concept of the circumferential margin, this is the area that the surgeon is cutting around to deliver the sausage, the tumour with the surrounding nodes. And what we found was that the high resolution MR that I developed, thanks to the technology that was available, but we focused in on the rectum and matched these individual grayscale images to the beautifully coloured histopathology images so that we could start to understand what we were reading on those scans. Because it's one thing getting a scan, but it's another thing actually understanding what you're looking at. Those are two different skills. So you've got to get a good quality scan, and then with that scan, understand what you're looking at to be able to say and predict what the pathology is going to show. So the big advantage is that the surgeon doesn't have a surprise, doesn't go, oh, the next day, it was all too much, I just had to close you up again. That was the regular conversation that we were witnessing from patients, and they would be coded as non-curative. Can you imagine going into surgery only to come out again knowing that the tumour's still there? It would be unheard of nowadays. But that was what was happening before the days of MRI, because they had no way of knowing. They had to just go in and explore, in inverted commas. But now, thanks to this technique, they at least know what they're dealing with. So that was the importance of staging by MRI, which we proved, and that was the Mercury 1 study. But there are these other two questions which have emerged really as a problem, in that there's no consistency in the patients who we think we can treat that are curable by surgery alone versus those who need more treatment, because they have a risk of either having a recurrence locally or having spread beyond and to the liver and the lungs. And the thing is that the treatments that are available, they're there, but you don't want to give somebody who doesn't have those risks such intense treatment, because it makes their lives miserable and there are irreversible long-term side effects. So, you know, sadly in the US and in sort of commercialized healthcare, these are sold as, you know, safety things. So, yes, if we give you more treatment, that's better, because, you know, you'll get more treatment and we can mitigate any risk at all, even if you've got no risk. Which I think for a patient who then has to put up with the long-term effects of that treatment, that's not really giving them the truth. And so I do believe that we need to have the patients take ownership of those decisions and also have information that's meaningful about their prognosis so that they can make a proper decision about how intense their treatment should be. Now, there is another problem, which is this idea that all the lymph nodes that you see on a scan are bad. And the way that radiologists are taught, not just in the UK, but around the world, is that they're taught to measure the size of a lymph node. Now, if you have ever had a cold or an infection, you'll know that your lymph nodes go up. Why do they go up? Because they're fighting. They're creating an environment to deal with the toxin. In this case, the toxin is cancer. So an enlarged lymph node is, in many cases, a sign that you have a very active immune system that is fighting against the cancer. So not all lymph nodes are bad. And actually, it's important to tell the difference between a good and a bad nodule, as it were. So I would, as part of Mercury 3, we're going to get rid of this term lymph nodes measure bad. We're going to actually start thinking about the underlying biology that you can see in beautiful detail on a scan. And actually, if you spend a bit of time looking at what's really going on with the tumor, there's so much more information to share with the patients and with the surgeon and the oncologist. So if you've got a traditionally trained radiologist in the UK or in Europe or in the US, this is what they will say about that lymph node. If you've got a Mercury 3 trained radiologist, they will say the blue things. So they will say, this is a good prognostic feature. Don't worry about it, because it's not the thing that's going to harm the patient. It's something that's helping the patient fight the tumor. And that's what we found from our initial work, which has been the basis for why we're doing the Mercury 3 study. So what we have already shown is that these sort of juicy fat lymph nodes are associated with a survival improvement. So for every patient that has more lymph nodes, what you're actually seeing is an overall improvement in survival. And that improvement is greater than the improvement you see from chemotherapy. That's how powerful it is. So the other aspect is that the advantage of imaging is that you're seeing the tumor before anyone's done anything to it. And in the past, we looked at some of the published papers, and they noticed that the size and number of lymph nodes could be a good prognostic factor, but they said it was because of the surgeon and their skill in removing so many lymph nodes. Or they said it's because of the pathologist and their sharp eyes at identifying so many lymph nodes. So it was all attributed to the skill of the physicians, to the surgeons and the pathologists, not to the patient who actually was producing these lymph nodes and actually fighting against the tumor. So this is how upside down medicine can be. So I think that's part of the re-education, because to change this idea that's been around since 1932 doesn't happen overnight. We have to generate evidence and evidence and evidence. So we've published, we've done studies, but what we haven't done is a prospective multi-center trial where multiple radiologists are testing themselves against the outcomes in patients who've had their scan and we know their outcomes, but also testing how we can use that information to improve the knowledge that patients receive when they're diagnosed. So that's the sort of components of the study. So it's not all, easy peasy, ignore the lymph nodes. There is some other things to think about. And one of these, and I'm sorry for the acronym, EMVI, but I'll explain what that is. It is, E is extramural, outside the wall. We love our Latin in medicine. I don't know why. It's a dead language, but in medicine, it's very much alive. So it's outside the wall, spread into the vein. Now, tumor spreading into the vein, rather than going into a lymph node, you can imagine has a totally different pathway. So if you are aware, maybe you're not, but the veins drain bowel they drain the bowel of its nutrients wherever the bowel is, including small bowel. And what comes from the bowel wall goes into the veins, and the veins then travel up in the body to the liver. And it also some of the veins go out sort of laterally out that way to the main veins, i.e. the inferior vena cava that goes to the lungs. So what you have is, I like to describe it as a highway for tumor. It's an, they've got a motorway. Why would they want to go down some back paths via the lymph nodes when they've actually got a really fast blood flowing channel to spread disease? So the veins are seen beautifully on MRI. I hope you can see it on here. What we're looking at here are these little sort of tubes. That's what a vein would look like. And what happens when tumor grows into a vein is those tubes become irregular and expanded, but they're always tube-like. So it means then we can see this before the patient has had their surgery, and we can say, right, this is a tumor that's behaving badly. It's wanting to go into the veins. It's trying to get elsewhere. What can we do about it? The thing that we can do about it that's proven to work is giving radiotherapy, because it shrinks the tumor in the veins and stops it in its tracks. If you don't do that, you have this sort of cartoon effect, I'm afraid, but it's a badly drawn thing. But these are illustrating all the draining veins that conglomerate into the main trunk, which then goes to the liver. So what we've noticed is it's not lymph nodes. If a patient develops spread to the liver, it's in 95% of cases because the tumor has spread into the vein first. And that's the thing that doesn't get documented at all currently on any of the cancer registries. Not preoperatively, not postoperatively. It's still about the lymph nodes. So that's the thing we want to change. And the other thing that we discovered relatively recently is that some of these so-called lymph nodes were never lymph nodes. They were actually seeds that had formed along the vein and formed these nodules. So they had been, and they still are, unfortunately. Pathologists look at a round thing and they're always congratulated on how many round things they find, and they call them lymph nodes because they're audited on that. So, a pathologist is only good if they can harvest more than 12 lymph nodes, and they have to call them lymph nodes. So when you've got a round thing, the temptation is to call that a lymph node. But actually, if you scrutinize these, which we're able to do, and that's one of our sort of sub-research projects, and you match them to pathology, and you say to the pathologist, well, what about this is a lymph node? Can you see a lymph node capsule? Can you see immune cells? Or is this, in fact, a lump of tumor in a blood vessel, because you can see blood next to that lump of tumor? And of course, then there's a sort of, there's a change. And I think, pathologists are beginning to become aware of this importance of not just calling every nodule that they've picked up a lymph node and actually making that distinction. But that distinction is important because this means that you have a tumor that's behaving biologically very different to a tumor that has just simply got a lymph node involved, because of this highway, this pathway to the veins around the body. So here you can see this thing, and it's got this funny shape. It looks like a sort of little animal with a snout, because it's following a vessel. Lymph nodes won't do that. They're just round and encapsulated. So this is very different. So we can't call it a lymph node, and we shouldn't be, but we have been, unfortunately. We've been very indiscriminate. So hopefully you can all see from the back of the room the difference between a node, a lymph node, which has got this nice capsule and it's got this little halo around it, which we should just say, well done, patient, for producing a lymph node. But this is what the tumor has done. So the tumor has ignored that lymph node and has decided to go straight into the vein. And as you follow that vein, you see the trouble that patient's heading into, because that vein is now going beyond where the surgeon is going to remove the tumor and the rest of the mesorectum, as it were, and it's going to travel beyond. So it's important for us to resolve it, when I mean resolve it, to see it, so to have a good enough quality scan to pick these things up, and for us to document that, to mark it for the radiation oncologists, for the radiotherapists, so that they can strike it dead, because that's what it needs. Because left alone, or left to then go straight to surgery, is a disaster, because that means the tumor has been free to travel and spread elsewhere. So yes, there is a lymph node, but that's not the cause of the trouble. That's the fight back. The cause of the trouble is this passage of tumor growing, wherever it wants, basically. So what we found is these so-called tumor deposits, that's what TD means, it's a tumor deposit rather than a lymph node, was associated with worse survival, worse so-called disease-free survival, i.e. events like a metastasis would happen within the first year in about half of the patients that had it. Whereas if you didn't have it, your survival was going to be 80%. So it's a big separation, and we haven't seen that kind of separation from any other staging system to date. So that's why this is so important. And yet with the lymph nodes, it's the opposite, that if you've got lymph nodes, you have a survival advantage. So you can imagine a scenario where there's two questions to be asked. Have I got tumor deposits? Have I got vascular invasion? But then there might be a third question is, well, do I have lots of lymph nodes as well? Because maybe the one versus the other might have a slightly cancelling effect. But if I have no lymph nodes and I've got tumor deposits and EMVI, I need everything. I need the works, and please give me the works, and I'll put up with the side effects because I need that. But do I need that if I've already got a 90% survival? Not really. It's not going to change that. The treatment's not going to change that. So, and that's the thing, is that you find that in some of the trials, the treatment doesn't change outcomes for a lot of patients because they were never going to benefit. They were always going to do well. So these negative trials are going to remain being negative because they've targeted the wrong patients. So that's another problem, is if we're going to advance medicine, you've got to be strategic. You can't just give everyone everything, because you'll never get the signal of the patients whose lives you wanted to actually save. So that's the thing. So this is patients who were going to primary surgery and were not staged using the new system that we're putting forward. And what we showed was that if we had used the old system, which is Duke's TNM, which is lymph nodes, ignore everything else, and T stage, there was no separation in the survival for those patients. You couldn't tell them apart. But if you use this TDV staging system, which is, are there tumor deposits? Is there vascular invasion? Is there spread into the veins? You see this remarkable improvement in prognosis. So what kind of report do you want? That one? You do want that one because you want to know that you're going to do well, but it doesn't help because you need to find whether you are in the blue line or the red line. And if you're in the red line, to maximize treatment, and if you're in the blue line, go ahead and have your primary surgery because you're going to do well. So we need, and I think our first involvement together at Red Trouser was charity was over the NICE guidelines, and your voice as patients, as stakeholders, was, I think, really instrumental in getting them to change what they were trying to do at the time. This was in 2020 during COVID. And what they wanted to do was to say every patient should receive preoperative chemoradiotherapy unless the radiologist thinks that the tumor is confined to within the bowel wall, and has no lymph nodes. So that was crazy because it meant then 80% of patients were going to have to be given radiotherapy because they were going to measure the quality of care by how much radiotherapy was given to such patients. And they would shut down units if they weren't complying with the NICE guidelines. So we persuaded them to say, you really haven't got evidence for this, despite what you think you can say. And actually, you need to retract that component of the NICE guidelines, and you should not make all the hospitals give radiotherapy when they don't think it's correct. Yes, so we managed to retract that, get that retracted, but it meant that we haven't actually got some guidelines anymore that actually can be implemented and enforced, as it were, in terms of quality guidelines. So we are back to square one with random decisions being made. And this is an example. We've been going up and down the country sort of talking about Mercury 3, and as a sort of baseline, just been polling the different MDTs, the multidisciplinary team meetings that discuss new patients. Like, what would you do if you were given information about tumor spread into veins and tumor deposits? Would you give radiotherapy or not? And literally, it was a flip of a coin, depending on which teams you were asking and who you were asking. So nobody knows what they should be doing with this information, which is another reason why we need the Mercury 3 trial. So this is them retracting as a result of our letter to NICE guidelines, and it got published in Lancet Oncology along with our letter. And I think Paul signed on behalf of the charity. So that's where we're at right now, and that's what we want to change. So this is what we're currently underway. Is we have the benefit of some really motivated hospitals up and down the country who are going to submit all of their 2019 scans, pathology, decision-making, outcomes, reports, and patient outcomes, whether patients survived or didn't survive, whether they got metastases or not. And this is going to be so valuable because we're going to be able to centrally review those scans and recode them according to this new system compared with the old lymph node system. What we are then going to do is present that data back to all of these different hospitals to say, right, what do you want to roll with now? Do you want to carry on with the TNM that you were previously compelled to use, or do you want to see if this TDV system is going to improve the information you'll give to your patients? So we'll provide them with the evidence base to change their practice, and we'll do that at each of these hospitals. These are the hospitals that managed to open and start recruiting. The counties, but essentially there is a hospital in each of these red counties. You can see there are large areas of the country where the hospitals just couldn't get going. Usually it's their R&D departments were blocking. Sometimes it was capacity, sometimes it was funding at the actual delivery sites. But for each of these, we think we've got enough geographic as well as demographic representation to say, well, if we can do it in these 15 hospitals representing these areas of the country, it should be possible then to have this rolled out to the rest of the country. So that's really the aim of this, and this is why this is so important. So they're in the process right now of uploading all the original scans onto a portal. So there's a lot of data sitting there. It's obviously a secure portal, and the scans are anonymized. We will have separately the original and the final histopathology reports. We'll also have the treatment decisions, the treatments actually given, and the outcomes data. We'll also have, quite importantly, which will be a measure of what impact it had on patients, the number of hospital readmissions and visits and blood tests and various things, the sort of things that ruin your life, that you don't really want going on after you've been think you've been treated and cured of your disease. You don't want to keep having to be admitted for various odds and sods. So we'll be measuring that, and we'll be looking to see what the impact of those different stages of disease, the treatment policies have had on those. And then prospectively, we will be measuring the quality of life and the shared decision-making processes that patients are being put through before and after the intervention of our new staging system. What we're hoping to show is that their shared decision will improve, that the information they receive will improve. And as a result of that, their treatments will be more strategic and tailored to their actual tumor, which will then have an impact on their quality of life. So those patients who really needed the treatment get that, and they have a good quality of life because they survive and they do well. And those patients who were previously overtreated, we will now see an improvement in the quality of life from getting the correct treatment. So that is what we're trying to do. So we want to, by improving the documentation of the stage of tumor when they're first diagnosed, we want to improve treatment selection, reduce overtreatment, reduce undertreatment, which it can be just as bad, but ultimately for the whole population, improve survival. That's what we want. And what we hope is that once we've got this evidence and publish it, say we'll have some data in the first year, we'll have data at every interval, we'll have data at 3 years and 5 years. We'll just keep adding to the data and the evidence to actually create a new standard that probably will be a new global standard for rectal cancer staging. So what will we be doing in the upcoming year? We're going to have this 2019 data hopefully loaded by the end of, certainly by the end of this year. And it's a big task, but I will be reporting all of them from 2019 from all 15 hospitals. So I'll be cross-eyed by the end of it, or maybe blind, but I will, what we will do is then use that information to compare the two different staging systems. So I'll report them using the old system and the new system, and we'll compare them alongside against the outcomes. We'll also pull out the information from the original reports to see, did they have the right detail? Unlikely, because they were never compelled to. So did they have the right detail? And if they didn't, what were the consequences of having the right detail? What were the treatments that the patients missed out on or got overtreated on that basis? So we'll be able to quantify the scale of the problem, hopefully by the end of this year. And we'll be able to measure the consequences of unnecessary treatment, and also for those who perhaps could have had more treatment and could have avoided a cancer death. So I mean, it's going to be depressing looking at 2019 data in this way, but the only thing that I think will keep us all going is to know that we are on the path to improving that. We can't change the past, but we can definitely make the future not as bad as the past. And that's really what's keeping us going. So thank you to Red Trouser Day for your generous support, because as you can see, it will save lives. And we wouldn't be able to do this so quickly without your help.